Hello audience, this is Dr. Jitendra Shekhar. Kindly watch my previous video on EEG. Now let's start with the introduction of EEG. Electroencephalography remains one of the principal tools in the practice of clinical neurology. The information learned from EEG testing differs in a number of ways from what is learned from radiological images such as MRI scans. Whereas MRI primarily furnishing anatomical information as snapshot in time, EEG captures electrical information over time. Thus the radiological imaging studies and electroencephalography are complementary techniques. EEG is used in a variety of clinical situations, but the large majority of EEGs are obtained as a part of the evaluation of seizures or epilepsy. Electroencephalography is a relatively young science. In 1875, Richard Caton was the first to report an observation of electrical activity from the brains of monkey and rabbits, though the techniques available at the time did not allow him to record these waveforms for posterity. Caton made his observation using a device called Thomson's mirror galvanometer. Hans Berger, considered the father of modern electroencephalography, was the first to record EEG in humans while working as a professor of psychiatry at the University of Jena in Germany. His first attempts at recording brain waves in 1924 were carried out using a string galvanometer designed to record electrocardiograms. Hans Berger at age 52, 1925, 1 year after he has began his work on the human electroencephalogram. This photograph shows one of the first attempts at recording the electroencephalogram in humans. The patient had undergone a left-sided trepanation. The recording attempt was made with silver electrodes secured to the scalp with adhesive tape but was unsuccessful. This patient was recorded sitting up. Later patients were studied lying on a couch with glass legs for electrical isolation. The first published recording of an electroencephalogram in a human. The top trace shows an electroencephalographic signal recorded from 2 needle electrodes in the area of a large bone defect. The middle trace shows the electrocardiogram and the bottom trace shows a 10 Hz calibration signal. The first successful recordings of the EEG in man recorded from a patient with an intact skull were made in Hans Berger's son, Klaus, using needle electrodes. This particular example was obtained when Klaus was 16 years old. The top trace of this figure shows an EEG signal derived from a pair of electrodes in the middle of skull anteriorly within the hairline of the forehead and posteriorly 2 finger breadth above the external occipital protuberance. The bottom channel shows a 10 Hz calibration signal. Visual analysis of the electroencephalogram. Wakefulness, drowsiness, and sleep. Wakefulness, drowsiness. Stage 2 sleep. Arousal from sleep. Natural sleep. Wakefulness. The posterior rhythm. PR. A note on the term alpha rhythm. Amplitude asymmetry of the posterior rhythm. Symmetry of frequency of the posterior rhythm. The posterior rhythm in infancy and childhood. Beta. Fast. Activity. The anteroposterior gradient. Posterior rhythm. The posterior rhythm is, as the name implies, best seen in the posterior head regions. The posterior rhythm should never be visible in the frontopolar electrodes. However, in addition to its location on the head, 2 other distinctive qualities define the posterior rhythm. First, it's a rhythm of wakefulness. Indeed, the posterior rhythm is the hallmark of EEG wakefulness in those patients who manifests as rhythm. Second, the posterior rhythm is predominantly seen when the subject's eyes are closed or when visual attention is lacking. Absence of the posterior rhythm as isolated finding is not necessarily considered an abnormality. In this normal, awake electroencephalogram, the PR is the most prominent waveform on the page. Each horizontal wave is generated by recording from the pair of electrodes denoted in the left margin. Each vertical division represents 1 second. Odd-numbered electrodes are placed on the left side of the scalp and even-numbered electrodes are on the right. Those with Z subscripts, for 0, are in the midline. Each of the 4 major chains of electrodes can be examined from the anterior to posterior direction, as indicated by the 4 vertical arrows on the left side of the page. The PR, a well-formed sinusoidal rhythm, becomes more prominent as each chain is scanned from front to back and is best defined in the channels that includes the occipital electrodes, O1 and O2, solid arrows. In this patient, as in most, the PR is of slightly higher voltage over the right occipital area, bottom 2 solid arrows, compared with the left, top solid arrows. EEG of the same patient, awake, demonstrating the effect of spontaneous eye opening and closure on the PR. The PR suppressed dramatically with eye opening. Note also that the PR actually begins to return 1.5 seconds before the eyes close, suggesting a period of relative visual inattention. The exact movement of eye closure is marked by the eye closure artifact seen in the frontal lead's hollow arrows. A note on the term alpha rhythm. Because in adults and older children the posterior rhythm's frequency is normally in the alpha range, 8-13 Hz. The posterior rhythm is sometimes referred to as posterior alpha rhythm or simply the alpha rhythm. A posterior rhythm below the alpha range is seen infrequently in children, especially at the beginning of the first decade of life, an age at which a posterior rhythm under 8 Hz is considered a normal finding. Adults may also manifest a slowing of the posterior rhythm below 8 Hz, most often marking as pathological state or occasionally a pharmacological effects. Most often, the shape of the posterior rhythm is sinusoidal, which is to say that the peaks and troughs of the waveform are similarly rounded and regular. In a minority of individuals, the posterior rhythm waveform is sharpened on one side and rounded on the other. This is referred to as spiky alpha variant and is considered as normal variant. More plentiful faster rhythm seen frontally and higher voltage slower rhythm seen posteriorly. Amplitude asymmetry of the posterior rhythm. Most often, the posterior rhythm is of lower voltage over the left hemisphere, the dominant hemisphere, compared with the right hemisphere. Usually, the difference in the posterior rhythm amplitude between the two sides does not exceed 20%. Therefore it is useful to set a threshold for posterior rhythm asymmetry beyond which an amplitude difference is considered abnormal. If the posterior rhythm's amplitude over the non-dominant hemisphere is more than threefold greater than that of the dominant hemisphere, it is considered abnormal. If the posterior rhythm's amplitude on the dominant hemisphere side is more than twofold greater than of the non-dominant side, it is considered abnormal. The dominant hemisphere tends to be more occupied with neutral processing because of the nature of the tasks it handles by nature of its dominance. In comparison, the non-dominant hemisphere is considered to be more idle and therefore would be expected to generate a higher amplitude posterior rhythm. Symmetry of frequency of the posterior rhythm. The frequency of the posterior rhythm should be the same over each hemisphere. Although a mismatch in the frequency of the posterior rhythm between hemispheres should be considered an abnormality, true difference in the fundamental frequency of the posterior rhythm between hemispheres is uncommon. The posterior rhythm in infancy and childhood. The PR can be first recognized as 3 to 4 months of age in infants born at term. Although in infancy, reactivity to eye closure is more difficult to demonstrate. At 3 to 4 months, a PR frequency of 3 to 4 Hz is expected. Through the first decade, the PR's frequency increases and reaches the adult range, which is between 8 to 13 Hz. Because the PR below 8 Hz is considered abnormal after age 8 years, the rule of 8 by 8 can be applied, meaning that by 8 years a PR frequency of 8 Hz is expected. Typical frequencies of posterior rhythm and lower limits of normal by age. Thanks.